Hi, everyone. Sorry for starting a few minutes late. First of all, thank you all for your interest in this webinar. My name is Karine Forgue. My colleague Florence Desplanches and I were the ones that organized the webinars during the past few days. We want to say that we're very glad to have the opportunity to discuss the resumption of activities of community organizations after the quite long COVID-related pause. We are fully aware that a lot of you have been in unclear positions with lots of questions about stopping or resuming your activities. So this is basically the goal today. We want to bring clarifications regarding this situation. We might not have answer to all of your questions, but we will do our best to bring explanations. As you may know, we ran 4 to 5 webinars in French this week. Due to the popularity of these events and the growing demand to have a session in English, we quickly organized this webinar in English. It is not that often that we have the chance to present in English at Montreal Public Health, but we're really happy to do so today. Considering that we have only a short time to organize this, please excuse our short notice for the invitation. Also, we did not have time to make an official translation of our presentation, so please be indulgent if ever you see any mistakes. That being said, the plan for today's webinar is a short presentation that will last for about 15 to 20 minutes. The rest of the session will be dedicated for answering your questions. Even though there's a part of the webinar that will specifically focus on questions, we invite you to share them in the Zoom discussion thread all along the presentation, and don't be shy. Before we start, it is to know that this presentation will be recorded. The PowerPoint presentation will also be sent to you after the webinar, so probably today. It will also probably be available on our website with an audio version of the webinar at some point, but I cannot say exactly when, though. We will have the same format for this webinar as we did for the French webinars. Because of high participation rate, all participants will be muting during the presentation. Now, without further ado, I'm glad to introduce you to Dr. David Kaiser, which will be presenting today. Dr. Kaiser is a public health and preventive medicine specialist. He's also medical chief of our sector. He's worked on many issues related to environmental health, including housing conditions, environmental noise, air pollution, urban planning, and more recently, he worked on the COVID-19. So, Dr. Kaiser, the floor is now yours. Thank you.
Thank you very much. Sorry for the 2 minutes of lateness. Thank you, Karine. And just maybe a thumbs up if people hear well. Is the sound okay? Okay, super. All right, so let's move right ahead. So as Karine said, the idea today is to present a few slides with some basic information around the recommendations for resuming activities in your organizations or maintaining, maybe in some cases, in the current context, presenting some of the available tools and then having a question period. Next. And this, by the way, to respect grammar guidelines, I think this is the right way to kind of, the right sentence, but resumption of activities in community organizations is not very easy to say, so I'm going to skip that slide. So, is it official? We're all living in this world where we kind of hold our breath at 10:30 or 11 every day and wait to see what the ministry is going to announce. And so we've been working, as some of you may know, for quite a few weeks on the issue of community organizations being able to open back up, because we know that is an extremely important part of the public health system and the support system for vulnerable populations in Montreal. And we're very happy last week to finally have official confirmation. So for those of you who didn't see it, didn't percolate down, or who want to be sure that it's official, it's official. So we had that letter last week to confirm the modification of the decree regarding suspension of activities in multiple sectors. And so the idea is that is across the board for community organizations in any sector, but that obviously it comes with the responsibility or the obligation to comply with public health directives. And then there's a document that came along with that that some of you may have looked at. It was fairly short, and the only thing I would say about that is, in the current context, we're always getting surprises, and we also know that the recommendations and directives change very regularly. So that document is already a little bit out of date a week after it was sent. It was already out of date the day after it was sent, actually. Next. Just a couple of things about the presentation, about what we're going to be presenting is these recommendations reflect our adaptation of the ministerial directives to the Montreal context. So trying to clarify some things that we know, around the types of activities that you all do and the context in which you're working. What I just said, the epidemiological situation can change rapidly. And so what's valid today may not be tomorrow. We try to avoid going into great detail on some of the things that may change more quickly. And so hopefully most of this will hold for the summer. There's no single best way of putting back together things that have been on pause for weeks or months, and I think it really depends on context. So the idea today is definitely we're not going to be able to cover every single situation, but to try and give broad strokes of the types of context that we know exist out there. And the decision belongs to you. There's no obligation. This isn't the ministerial directive is not an obligation to resume activities. It's a permission to resume activities, knowing that a lot of them are essential for the populations in Montreal. And finally, just a point of order, which is if you have questions, put them in the dialogue box and they'll be picked up by my colleagues. So this, I'm obligated to, this is an obligatory slide in any presentation we make. We get a message from the ministry if we don't put this in the presentation. Cough into your sleeve, wash your hands, keep your distance, cover your face, limit your travel. So obviously all of these things still apply. All of the rest comes around this, but the distancing guidelines, rigorous hand hygiene, really strongly encouraging face coverings whenever it's possible, and especially when it's most pertinent, which is indoor activities, group activities, activities where people are having more difficulty maintaining their distance, and obviously respiratory etiquette are still the fundamental basics, and then we'll look at some of the things that how to operationalize that. And obviously, we're in a more favorable epidemiological context today than a month ago, and we're very happy about that. But there's still active cases. So just order of magnitude, where if you follow the numbers, you know that we have about 60 or 70 cases a day over the last 2 weeks, and so on the island of Montreal, that's still probably around 1,000 active cases based on how long the disease lasts, and so there is still transmission in the community, and it's still super important that people who are supposed to be isolated at home are isolated at home, and that they respect that isolation. So active cases of COVID, people who have been in contact with a case or a suspected case, people presenting symptoms of COVID, and those people, if they come to your organizations, not only should they not be participating in activities, but they should be strongly encouraged to get tested and to isolate. People awaiting results of a lab test, and people returning from travel outside Canada within the last 2 weeks. So those quarantine guidelines for travel are still applicable. And a word on personal protective equipment, and this may come up in the questions. More specific, we'll try to answer more specific questions, but I think a couple of important points are that for your staff who are in direct contact with clientele, we do recommend a procedure mask, and again, that's for people who are in close contact. Just the idea being that a procedure mask is manufactured with respect of certain quality criteria, and a cloth face covering is not necessarily a direct replacement, but obviously if procedure masks are not available, then a cloth face covering can be used. And again, important that personal protective equipment does not replace basic measures. If you can maintain physical distancing, then that's a preferable situation than having to resort to PPE. that it only provides protection when it's used properly at the right time, and that improper use can actually be riskier than using no protection at all. And the classic example is a mask taking it on and off multiple times in the day. Every time you take it on and off, you're potentially exposing yourself to whatever is on the outside of that mask. And so sticking with the basics is always better than sacrificing the basics and trying to replace it with PPE. And you have some links there for more information. So just drilling down into that a little bit, looking at specific recommendations. The procedure mask, as I said, is really for interventions with where you're not being able to respect that physical distancing. And the two first rows that you have there are the idea of 15 minutes being the criterion we've used up till now to define kind of a significant time duration of contact. So for brief interventions, procedure mask is sufficient, whereas for longer interventions, so if you're sitting down with someone for a counseling session in a small space and you're not maintaining that distance, then eye protection is recommended. And eye protection, that can mean either a face shield that I'm sure some of you have seen, or glasses with side covering, so safety glasses. Looking at interventions with higher risk of contact, so higher risk, for example, of aggressive behavior, then even if they're brief interventions, then the eye protection is required in addition, or recommended in addition to the mask. And then just the last two are cleaning or handling personal effects. So when you're cleaning a room or cleaning a surface, or when you're handling personal effects, it's recommended to use gloves. And you see that in the first three scenarios, there's no gloves that are recommended, because the idea is that it's much more effective to be washing your hands before and after these interventions, and to be wearing gloves, where you always have the risk when you take them off of contaminating yourself. And then there are some basic recommendations around adapting the workplace. So these are not different necessarily from what you already do. Some of them are just a little more, there's COVID specificities, but it goes from the environment. So posting signage, providing access and increased access to hand hygiene, whether that's hand sanitizers or sinks with soap. Physical separations when 2 meter distance can't be respected. So in a retail context, that's like a cashier at the grocery store. That person is going to be in contact regularly with people at less than 2 meters, so you put a plexiglass. Same thing, a bus driver. So in your context, if you have people who are, for example, doing transport, or people who are doing service à la clientèle, where it's going to be hard to respect that distance, then a physical separation is a good measure. Visual cues, so you've seen this a lot, putting an X every 2 meters where there are lineups, helping people respect that distance. Encouraging unidirectional travel. So this is, you may have seen this in grocery stores or in other settings, where it just facilitates, again, distancing in that you don't have people going in both directions at once. And obviously this is always to the extent possible, and in some cases that may not be possible. But where it is, it's another environmental measure that can be useful. Increasing frequency of cleaning. So I'll say right away that this is a recommendation that will be really context dependent. And the idea is that given your capacities, given the types of clientele that you have, and given your context, it's really prioritizing those high touch surfaces. So elevator buttons, door handles, washrooms, sink faucets, all that kind of stuff, is prioritizing that, and then working backwards from there. And so the idea of increased frequency for some places may not mean necessarily daily cleaning of places that aren't high touch. If they're clean once a week, then understand that twice a week is an increase. But I think the more important message is that high touch surfaces should really be cleaned as often as possible and multiple times a day. Limiting repetitive contacts on surfaces. So this is the examples of if you don't have an air-conditioned space, you could leave the door open, or have someone have a door opener, so that every person who comes in is not touching the door. So those are a lot of places where there may be some adaptations that are possible to avoid that everybody is touching those surfaces. Limiting the use of non-essential shared equipment. So this is, again, context dependent. There are things that need to be shared by definition. Again, always have in mind easy examples in a retail setting, but the Interact thing is getting touched a million times a day. It just is what it is. But there are other things that you can limit the use of, and a water pitcher, dishes are good examples. That doesn't mean that you need to be going with disposables. The idea is not that everything needs to be single use. The idea is just that you're more in a context where people are bringing their own water bottle, bring their own dishes, or doing their own, managing their own equipment, and trying to limit it if you can. And then increasing ventilation. So again, this is maybe easier in the summer, not necessarily when it's 40 degrees out, but for many days in the summer, natural ventilation may be a good option, and we'll see where we're at in the fall. We'll come back to that. So just a few slides on different types of activities, and it's fairly repetitive, so I'll go through it quickly, but the principles are always the same. If feasible, the idea is for group activities to still be maintaining, or if they were stopped, to resume them at a distance. So what can be done by phone or video conferencing or by using technology, that should still be an option that is in the forefront. But when it's not feasible or not well adapted to the type of activity, then it's resuming those in person with preventative measures. So hand washing, all of the things we just mentioned, encouraging using the face covering whenever people are inside and in groups, limiting sharing equipment, disinfecting the spaces after the activity, and outdoors, respecting those physical distancing precautions. Similar for individual activities. The idea is if they can be maintained, at least, and sometimes it may not be entirely distance, but what can be maintained at a distance should be, at least for the foreseeable future. But if not, then it's adapting the physical locations where you're having people come to always aim for maintaining that distance, wearing a mask so the procedure mask when the distance can't be respected, limiting sharing of materials, and disinfecting. And I would add here is where if you have small rooms, you're doing one-on-one or small groups, and you really can't adapt the activity to the space, then it's adapting the space to the activity, and this is where physical barriers sometimes might be useful. And so basic activities, meaning all of the stuff that including team meetings, all of the kind of regular functioning of your organizations. Again, trust me, I know that Zoom and Teams do not replace in-person meetings. We've been living with this for 3 months, but for the foreseeable future, the idea is still to maintain distance activities to the extent possible. And again, there may be some prioritization in there, things where it may sometimes be really important to be able to see each other in person, but the idea is to always aim for maintaining activities by phone or video conferencing on technological platforms to the extent possible. And then when it's not feasible, oh, sorry, go back for a second, Florence. When not feasible, the ideas are the same, but in addition, there's a notion of total number of people. So, I mean, a team meeting of 4 people, that may be fairly easy to manage the rest. So maintaining distancing and all of that, but a CA, annual general assembly of 150 people, that's probably not something that even if we're going towards larger gatherings being allowed, I think we should be planning that as a distance activity, because the idea is that it's going to be very hard to respect the rest of the guidelines. And then door-to-door. So door-to-door activities can be resumed or can be taken up again. The idea is to again prioritize based on the benefits of really doing door-to-door versus other ways of reaching people, because this is a situation where there may be more risk of transmission being out in the community and in direct contact with people. At the same time, there are surely activities where it's important to have that direct contact. So the idea is, to the extent possible, staying outside, so either the building or the apartment, wearing a mask because you're going to be in close contact, or if you can't maintain that distance, frequent hand washing. So, doing door to door, you should be equipping people with disinfectant solution, and then limiting direct contact with people or objects inside. So it's fairly straightforward. What's next? And then, so distribution, things like food drop-offs or other activities where you're sending out, maybe receiving stuff and sending stuff out. Again, the idea is where possible, doing that outdoors. So that's always been the recommendation. And again, it's always important, that this is adapted to the context, the specific clientele. There are people who can't come and pick something up at in the front of their apartment building because they have limited mobility. It has to be adapted to the objectives of the activity and the clientele that you're working with. But again, washing hands before and after, respecting physical distancing, and making sure that there's limited contact between. So the last thing, which is making sure that users are in contact only with the equipment or food that will return to them. So the idea is that the same way in an office environment, you're trying to avoid sharing, non-essential sharing, the same idea here. And outdoor activities, there's really nothing to add in terms of specific recommendations. We're generally probably easier to respect physical distancing for most activities. Maybe with certain clientele, that's more of a challenge, and that's where there's still possibly a role for PPE for certain types of activities, certain types of clientele. So these are, Karine mentioned a series of webinars were held this week, and these were some of the questions we got. So will I be able to access my premises? The answer is yes, and I think that I'm happy to see what the situation is for your organizations, but this has been, I think, it's been a kind of gray zone over the last couple of weeks, and it's something that we've been working on to clarify. But the idea is that there shouldn't be any reason why you can't access your premises, and if you're not able to, then that's something that just needs to be clarified with the owners of those premises, which are often municipalities, boroughs, or the city. Can people over the age of 70 attend a community organization? And the answer to that is a more clear yes. So again, at the present time, it's important to recall that there are no restrictions on community dwelling elderly in terms of going out for their daily activities. That may change again, but at the present time, there isn't a restriction there. And so it's really more about the recommendations to those individuals to say, well, they need to take care of themselves. There are certain, there need to be more watching out for their health. And on your end, you may pay more attention to making sure that all of the measures are well in place, but there isn't certainly people we want the community dwelling elderly to be able to access community services. And the same rules apply to all ages. So this is a trick question. No, it's a question that we have a different answer to today than 2 days ago, than a week ago. So in case you have trouble keeping up with the constantly changing guidelines. For the moment, what we have is that the 2 meters distance applies to adults, except for in certain situations. So I'll stick to age first, and then I'll come back to the other one. So 2 meters distance applies to adults, and then for adolescents, let's say, there's a 1 meter distance, and that's primarily of interest in the school environment, and then for daycares and for children, young children, the idea is that we're not looking to enforce distancing in young children. And then the other nuance is not based on ages, but is based on the types of activities. And again, honestly, my professional opinion, if I were in your shoes, I would probably always aim for 2 meters and not try to figure out which activities are 1.5 meters and which ones are 2. But the ministerial perspective, what you probably saw earlier in the week, is that for activities where people are sitting down and not talking and not laughing, and kind of looking straight ahead, and like a movie theater where you're watching a boring movie, because I mean, if it's an interesting movie, you might be chatting or laughing. But if there's really people sitting, no movement, then the 1.5 meters holds. But I think that it's probably easier to always tend for the 2 meters until further notice, but that nuance exists. So I'm going to go really quickly through these slides because you're going to have them, and it's just in case you don't know that these things exist, to indicate they exist. So the NSPQ, the National Public Health Institute, has over the last months, every few days almost, puts out new leaflets for specific sectors. So there are a few that may be of interest for some of you. There's one specifically for community organizations. There's one for organizations that offer housing or shelter. There's one for that isn't for community organizations, but it is for health services that are delivered at home. So where there may be parts of that are of interest for organizations that do similar work, and for delivery services. These are all in French. They're not available in English, but they may be of interest. There are, I mean, 1,000,001 training videos and activities out there, but again, the SPQ has a specific training session for employees and managers. So the kind of occupational health perspective that may be of interest for some of you. And on a similar note, this is the federal government's tool for some of the questions around, again, integrating workplaces, looking at how to deal with controlling COVID-related risks. So this is available in English. And from the IRSST is the Occupational Health Research Institute in Quebec. So again, looking for small and medium-sized businesses, which you are not, but which may resemble some of your contexts. They have some decision support tools, again in French, but for those of you who are interested to know that exists. Not sure if there's another one. Yes, and so this is this is specific to community organizations, which is more of a kind of a question answer, but specifically developed by what you see, la coalition des tables régionales d'organismes communautaires, so specifically for the community sector, but again available in French. And obviously the ministry and the provincial government, as well as the federal government, have a whole lot of stuff that you can print out and look at in terms of providing information to your clientele. So I believe that's the last slide. Yeah. So thank you. And for a question period, I've seen things go by. So the idea is we'll start with what's there. We'll answer as many questions as we can to the best of our ability, and then after the webinars, where my colleagues are compiling some of those frequently asked questions, and it says in French. I would say if there's a interest, I can't commit to a timeline, but I think that we could definitely figure out how to translate some of that because I think it may be important. We'll see what we get in terms of questions, and we'll go from there. So I think that's my cue. We're going to start answering questions. Yes.
Thank you, David, for your presentation. So how it'll work, we'll see the questions you've already put into the dialog box. First, we have a question from Julia. And sorry, I had problems with my camera, technical issues. So currently we have moved our therapy groups to online, which is not ideal because it's mostly talk therapy and not what we mainly do, creative arts therapies. In fall and winter, can groups 6 to 8 people come together to participate to an enclosed space for 2 hours if we adhere to the sanitary measures? I heard that the virus can linger into air in enclosed space. Should we avoid in-person groups indoor? Is it too risky? Focus on in-person individual service instead. So that's a good question. David, what would you be your answer?
It's a great question. So I'm not going to give I can't give a easy answer to that, but I'll a couple of parts. One is that it's really hard to know where we'll be in October. So in terms of fall and winter, we're going to have to cross that bridge when we get there. Honestly, I think what we are presenting today, as I said at the beginning, I hope that it holds for the summer. And then we'll see over the summer where we're at and where we're going. So that would be the first part. For the immediate term, and if nothing, if we maintain that over the winter, great. But the immediate term, I would say it comes back to the idea of prioritizing. And I think you had it in your question is, if the fact of doing it from a distance really impacts on the quality of the service or the objectives of that activity, then that may be the type of activity that you prioritize for bringing people back in person. And I think that type of counseling or therapy, some of that stuff is probably really type of clientele may be really affected by a distance modality and may really be more effective in person. And then it's a matter of following the guidelines. And so ideally, you would have a room that's big enough to keep people at 2 meters distance. You have people, wearing a face covering when they're not talking. You have everybody rigorous hand hygiene, and you have you try to make sure that people who are supposed to be in isolation are not presenting themselves in person, and that they know that before they show up, that they shouldn't be showing up if they're sick or if they're a contact. So I would say it's a good example of you're allowed. So there isn't a restriction on that specifically, a legal restriction on 6 to 8 people in a group. But I think there's a prioritization to do in saying what are the activities where it's really important for me to have people in person, because obviously the risk of transmission is higher having 6 to 8 people in a room than having them around.
Thank you, David. So we had another question about support for community programs to acquire PPE, and there was a suggestion of a resource in the thread. Next question would be, I've read that even if it's permitted to open, organizations will be encouraged to continue remote work if possible. Is that still the recommendation?
So I think that's what I just answered. And again, I really want to reiterate, or I think it's important that it comes down to the objectives and your ability to meet them. And so that is that decision comes back to you. You know your clientele. You know what the objectives of your activities are, and you've seen, I'm sure, over the last 3 months what you've been able to adapt successfully, what works. Or if you were on hold and you're restarting, you can always try, using a distance modality and see if it works. And you'll see if people aren't showing up, if it isn't working, then those are the kinds of things where it may be worth bringing them back in person.
Thank you. So next question is about mask and eye protection. Do you recommend mask and eye protection or a plexiglass visor that covers the whole face? That's from someone working with kids.
So I would say that the question of protection for adults who work with kids is very wrapped up with the issue of daycares where that's a specific work environment with the union context, the legal framework, and it's part. I mean, those aren't community organizations. Those are delivering a specific service. So I want to be very careful because try to be coherent across, somebody in a community organization working with kids and somebody in a daycare working with kids. What's the difference? If the only difference is that they're two different ministries that regulate them, then that's not a very good health reason. So I think that the choice will come down to organizations to some extent. But what I would say is that the public health perspective on that is kids need to be able to be in proximity with each other. And kids, if you're doing activities with kids in general, it's because there's interaction there. You're not like putting the kids in a room and watching them from afar. And so in that sense, I think that distancing is probably in many of those activities hard to maintain. And then it comes down to the type of activity. So if the idea is that there's interaction with the kids and in your community organization, especially if you have more vulnerable people who are delivering activities, more elderly people or people with chronic diseases, then I think PPE is not a bad idea. So a mask, and I personally, and I think professionally, safety goggles are a little less scary than a face shield for young children. But that's, it comes down to your interaction with the children, but I think it's not a bad idea. That being said, come back to the beginning and say what's decided finally in the daycares and how it plays out, I think will have an impact on what the expectations are from your employees or your volunteers, and it may help make that decision. Not a very simple answer, but I want to be very careful because there are a lot of it's not as simple as just a straight health answer, but I would say from a health perspective, we have to balance kids' needs and the idea of doing activities with kids with protecting workers. And I think that PPE is not a wrong choice in that case.
Thanks, David. Next question would be, we've noticed that guidelines are very difficult to comprehend for individuals who are illiterate or having learning disabilities. The visuals that you showed earlier help, but more are needed to welcome. Is this a priority?
Yes. Simple answer, yes. And what I would say is if you have specific, I think what comes out of these webinars also is material for us to understand the needs. So if you have specific examples, any of you of needs or suggestions, and yes, absolutely. Does that mean we do it well? Not necessarily, but I think it's something we're very sensitive to. And same idea with language barriers and different kinds of barriers to understanding the guidelines. So yes, but any concrete suggestions are more than welcome.
Great, thank you. Next question from Ruth. How long does someone have to be symptom-free before returning to the program?
Yep. So currently in Quebec, the guidelines have been the same essentially the whole time. So somebody who is a confirmed case needs to be spending 14 days in isolation. So that's no matter what, 14 days from the time the beginning of their symptoms or the time of their test if they didn't have symptoms, but 14 days. If at the end of that 14 days, they've been at least 2 days without a fever and at least 1 day without any symptoms at all, they're done their isolation. So it's a 3-part answer because it's at least 14 days. If they have no more symptoms after 5 days, that doesn't change the fact that they're supposed to be at home for 14 days. And then if at the end of that, they've had 2 days without a fever and a day with no symptoms, they're good to go. And then it's easier for a contact. For a contact, if they don't develop symptoms, so if somebody's been in contact with a case, it's 14 days. That's what it is. 14 days. If they haven't developed symptoms, they're good to go.
Okay, great. So next question is about public water fountains. Are they open again? If not, what will be done to hydrate vulnerable groups who do not have access to water in this heat? Yep. We are very concerned about this. Thank you.
Yep. And so are we. You can encourage your, I'm going to answer So don't forget, encourage your members and clientele to go to the City of Montreal's website, so montreal.ca, and the page, I think like it starts with a COVID thing. If you brush aside the COVID thing, there are a series of kind of priority buttons, and one of those is heat wave. And if you click on that, you come to a page where you can click to get to a map. Doesn't answer the question on fountains, but the map is pools, splash pads, beaches, all of the stuff that is open. So it gives you a real-time information on what is open. So for people who are mobile and go down to the splash pad and hide and stay cool during the day, it's a good option. So that is one part. The other part is there isn't a publicly available map of fountains like real time in the same way. But the short answer is the vast majority of them are open. So we worked on that 3 weeks ago when we had our first little heat wave. And since then, I can confirm that the vast majority are open, and that people should be encouraged to bring along a water bottle from home, and they can fill those up in all of the parks where there are fountains at the outset. The only ones that are closed are a few that had much higher lead levels. So this is totally unrelated to COVID. There was lead sampling done starting last year, and there's a small number of fountains that had high lead levels and hadn't been fixed yet. Those are closed, but it's a small number, and across the island, the vast majority are open.
Thanks for the specification. Next question is a question we actually had in all our French webinars. Is it recommended to take temperatures as part of screening, and what temperature is a concern?
Yeah, so short answer I would say is no for your organizations. You can find information on the INSPQ's website more detailed, but the general perspective is that temperature screening can be part of a package of preventive measures in workplaces. So it's not that it's wrong, but it's never recommended on its own. So just like having a laser thermometer at the entrance and screening temperature is not recommended as an intervention on its own. It can be part of, let's say, in workplaces where you have an employee screening in place and you do a little checklist of symptoms, you can screen temperature as part of that. It wouldn't be wrong. But it's not something that should be done alone, and it's certainly not something that is obligatory, and that I would think that in many of your contexts, it may be difficult to implement and may be a barrier to accessing services. And in terms of the temperatures that are used as a cutoff, I believe, and somebody can probably go on Google and find it as quickly as me, but I believe it's 38.3 that was used a lot of places. But I honestly think that in your context, I wouldn't see that it's an intervention that is very well adapted.
All right, next question. We've heard that some crisis centers are required COVID tests in a mandatory quarantine period before admitting a new resident in their shelter. Very challenging. How can we navigate this?
What kind of an organization, or what kind of a setting?
It's in centers admitting new residents, but it's not specified. It's for shelter.
Okay. So that's a great question, because the testing guidelines have changed quite a lot over the last month, and it's true that the latest guidelines that were put out last week, I believe, had a series of groups that were could be prioritized for testing, and within that list there is testing at admission for any kind of closed environments, and that includes CHSLDs or seniors residences, but also includes things like shelters, prisons, anywhere where there's a more closed environment. So yeah, that is in those recommendations. It's always a challenge to not provide contradictory information, but what I would say is many settings outside of the healthcare system we'll have challenges screening people at admission and screening them continually, I would say. And my perspective for you would be that if it is a barrier to access to care, to services, for vulnerable populations, then it needs to be really thought about carefully. And that doesn't mean that that it couldn't be useful, but I think that it needs to be seen as part of a package. And if it keeps people from accessing services, then we're not necessarily further advanced. So I'm hoping that that doesn't contradict the ministry's perspective, but I really think that it will be an ongoing conversation over the next few months, because it's not in the first priority. So if any of you have seen the priorities, it's number 16 in a list of 22. So it's included. And I think that that's interesting for settings where you have the capacity to do screening, the clientele are up for it, and it can be useful in the kind of preventive mix. But in settings where it's going to keep people from having access to care, then I think it needs to really be taken with a grain of salt.
Thank you. So next question is also about screening. What screening questions should be asked to our staff and members?
So this we could. I don't know if it's in the tools that are already in the PowerPoint, or we could easily add it, because I mean, basically, what you want to be looking at is there's a list of what are called A symptoms and a list of B symptoms, and the A symptoms are what we've all heard of: cough, difficulty breathing, sudden loss of smell, and fever. And the B symptoms are more general things like fatigue, general malaise, more flu-like symptoms, including gastrointestinal symptoms. And so if you were to have a screening, kind of symptom screening at the start of the work shift, then it would be based on that. And there are plenty of examples. So Karine, we can make sure that that's in the PowerPoint specifically.
Yeah, I'll look forward for it. Next question is it recommended for volunteers to go to residents in their home and to offer friendly visits?
It's a really great question, and I think it's, you know, we address kind of door to door. Obviously, in the health system, there are still situations in which we need to meet people where they live. There are still soutien à domicile. There's still services that need to be delivered at home. For your organizations, I think I would use that parallel to say things that are essential in the same way, you know, we talked before about having people come to you. So if it's for things that are really not going to happen if it's not in person, counseling around conjugal violence, you're not going to do that over the phone. You're going to bring somebody to you. In the same way, people who have extremely limited mobility, and you're delivering essential services, I think that needs to be looked at, and just putting the preventive measures in place. Friendly visits, I think it's probably somewhere in between, in the sense that there might be other ways. Again, unless it's people with really, you know, severely limited mobility who can't get out of their homes, there may be a middle ground, meeting in the park rather than going to people's homes, or figuring out ways of adapting that. So that's not a straight black and white answer, but I think it comes back to that spectrum of, if everything that can be adapted should be adapted, and for meeting people where they live, the adaptation could be meeting them outside in the park next door, or meeting them for a chat on a bench out front rather than going into their home. But obviously there may be situations where that's not possible.
Thank you. Next question is that it was recommended to set up an isolation room for those clients and staff who exhibit symptoms during work or activity. So could you add precisions about that type of isolation room? What would be the recommendation following? Sorry.
Maybe I'm not sure what this refers to. Karine, I'm not exactly sure what this refers to. I mean, unless we're speaking specifically about shelter, like a residential setting, but can you help me out?
It's not precisely done here. As we can.
Okay, maybe the person who asked that question.
Add specification. we'll continue, and if ever you want to put it back into the thread, that would be great.
And then, like, can the person unmute themselves? Just the person who asked that question, just say it out loud. Maybe it would help me understand.
Sure. Florence, could you unmute Maria New?
Yes, hi, my name's Marla. I work in the Indigenous sector, and this recommendation came out of our, I guess, our réseau of community groups in the Indigenous sector in Montreal. There tend to be clients that move from, let's say, PAC or Resilience or some of the other, and our organization, Native Montreal. So basically, it was recommended that we set aside an isolation room. So let's say a staff member halfway through the day starts to exhibit symptoms, but it's not clear at this point, do we, what does that look like? Do we have to have a special covering over the door? How long do we keep them there?
Okay, good. Okay, so I guess my first answer would be probably, I don't want to contradict something that I haven't, I'm not sure exactly what everything that there is behind it. What I would say is that the usual recommendation is to send people home as soon as they develop symptoms. So employees, volunteers, and or clientele or members. So there's probably something specific that the network was looking at in developing that. Maybe we could follow up after, because we have obviously links. I have colleagues who have worked with Resilience and with PAC in the last few weeks. So I would follow up with that maybe outside, but the usual recommendation is to send people home. Send people home and tell them to go get tested. If they don't have a home, or if there's some reason why you're keeping them there until they can, to figuring something out, then I think the short answer would be no. There doesn't need to be any really specific, it doesn't need to be a specific setup. If it's a room apart, the person puts on a mask, is not touching anything, isn't in contact with anybody else, then that would, I think, be totally sufficient. Doesn't need to be like a negative pressure room, somebody who just started developing symptoms. You put a mask on them, they wash their hands before and after they touch anything, and they shouldn't be staying there any longer than they need to. But at the outset, the idea would be to be sending people home if they develop symptoms.
Okay, thanks. Next question is also on PPE. So if staff share an office, do they have to wear PPE during working?
Great question, and the short answer is it's usually that the general recommendation would be yes if they are with less than 2 meters from each other. So again, if they share an office and you set it up so that there's enough space between them, and or you put you put a plexiglass, so it's or any other divider, physical barrier, then not necessarily. In those office environments, we're recommending to use a face covering like in any other kind of indoor environment is not a bad idea.
Okay, so we have another question about the 2 meter with working with children. I think that's something that's going to be included in one of our tools with frequently asked questions, because that's something that really came frequently. Did you want to add something to what you've already said, David, or?
I don't think so. I'll just say that again. I think it'll be an evolving situation between now and when school starts, in terms of seeing what is worked out for the school and daycare environments, and then seeing how that translates to community organizations. But for the moment, I think what's important is that the distancing guidelines between children have been changed, and so we're not trying to like separate children from each other. And then for your employees or volunteers, I think it's not a bad idea that they be using PPE when they're really running activities with kids.
Oh, thank you. Another question on PPE. When working with people with dementia, is it still recommended that the clients wear PPE, knowing that's a difficult reality for them?
Clients. So I guess I would have to know what the exact situation is, but in a context where so let's say people are coming to you for individual or small group activities, and you're able to, depends obviously what level of cognitive impairment, but if people are able to say stick to setup where they're 2 meters apart, you make sure that some kind of crazy noise going on, hopefully that will stop. They're able to wash their hands before and after, then no. Again, the recommendation, so I would separate PPE, where we're talking about procedure masks, eye protection, gloves, from face covering. So any type of face covering. In an indoor environment where you're, around people, me and you, I think we should try to wear face covering also as kind of a social norm as much as possible. But somebody who that's going to make them decompensate or is totally unworkable, then what you need to put emphasis on is the distancing and rigorous hand hygiene, and making sure that if somebody is exhibiting symptoms, that you take appropriate measures. So especially with people with cognitive impairment, that may be one of the things that really needs to be thought about, is making sure when they're coming on site or you're going to them, that you're being attentive to symptoms.
Great, thank you, David. Another question is on what do we do when an individual more vulnerable in the greater community is openly disregarding social distancing measures while spreading misinformation about COVID-19 that can put a vulnerable community more at risk to contract and spread COVID, and when SPVM won't intervene? That's not an easy question.
Where is this question? Just so is there a question or is it a comment?
They were both. It was also a comment in first place. So people experiencing homelessness don't have easy or regular access to official sources of information, while some people experiencing homelessness suffer from mental health issues. So the question followed, what can we do when an individual is in the greater community is openly disregarding social distancing?
I went in. No, I don't have an answer to that. The answer is that we're always trying to balance individual freedom and population risk, trying to balance COVID-related risk with overall impacts of our interventions. And I would say, so personally, I have been here with the police for the last 3 months, trying to make sure that the interventions that we're doing to protect the public don't have the least amount of negative impacts, and that's often very hard to navigate. So I think in this context, we're always trying to go with education, an approach to get people to follow guidelines, and trying to avoid coercive interventions and interventions that may have really serious negative impacts. But I don't have a good answer to that. I think it comes down to different communities, and if there's a specific issue that the colleagues that are working more on homelessness can help with, and I'd be happy to pick that up after.
Thank you, duly noted. So here there's a question about earlier slides stated that organizations could reopen subject to the physical workspace being adapted to allow proper distancing. Will there be any standards enforced by any sort of public official or prerequisite to being able to reopen? I tend to say no, but yeah, exactly.
This is an easy answer. Thank you. It's good to have a soft, slow pitch every once in a while. So no, the answer is there's no, to my knowledge, not going to be any specific enforcement arm of this. It's really up to you to set up your workplaces according to the guidelines.
All right, thank you. Next question is also about children. Given that children in daycare do not need to distance and wear masks, does the same stand for intervention groups with preschoolers?
Yep, absolutely. I would say it's exactly the same. The idea is to not put that, A, to not put that burden on children, and B, to not put that burden on the people who are trying to manage children. And so yes, the same applies.
Thanks. So another question is about if we make outdoor activities to be more safer, how can we handle the cleaning of the toilet? Is there one in the park? If there is one in the park, sorry. I'm not sure. Are you ready?
I'm not sure, but the answer or the toilets are in probably the top of the list of things to prioritize with the limited cleaning budget because a they're high use generally areas, so all of the the door and the sink and all that, but also because although this is a respiratory virus, we know that a lot of these kinds of viruses are also can also be transmitted through what we call fecal oral transmission. So that is to say, like a gastro, they're in your poop. And so toilet facilities are really our priority for cleaning as really as often as possible. And then the public facilities, I mean, we've given that same message to the city. So I can't guarantee how often they will be cleaned, but the idea is to give people access to toilets in parks because otherwise they pee in the bushes, and to clean them as often as possible.
Thanks. With the rural evict being closed, where are people who don't have a dwelling supposed to go to await test results, or if they have symptoms?
So I think this is a very big question, which is being answered by my colleagues who are working on the homelessness file, along with people from the city and the CIUS, the homelessness team. And short answer is for people who, for cases, it will not be the VIC, but it will be other hospitals in the system that take up that part. And for people awaiting test results, it will be much more community-based. The idea is to return to a model where community organizations, so the big shelters and community organizations, are able to manage that within their walls with support in terms of, and that's the work that's going on right now, is seeing what needs to be put in place to make that possible. But it's a job that is being done right now with the shelters, with the various organizations in terms of making that happen.
Thank you. In the summer heat, we will need some air-conditioned space, especially seniors. Do you know when libraries will open?
I was just asking that question of the ministry just before I started this webinar, and I think the answer was soon. So we've been working with the city for weeks now in order to help get them ready for opening things like libraries. So short answer is I think it should be as early as next week that some of that starts to open up, but don't quote me on it because things change quickly. But we're working on when we see that as an essential resource for many reasons. But it's a very good question, and it should be soon.
Okay, thanks. So there's not much question anymore. We have an information about Architects Without Borders that offer consultations about adapting your spaces. So that's a good reference.
Yep, super.
Were there any more questions? Because right now it doesn't seem to have more. Is there some question that I skipped or that I forgot to ask? If yes, you can add it up in the chat right now. So we still have until 3 o'clock, but if ever we finish earlier, that's okay too. Okay, so working with seniors with hearing loss and anyone with hearing loss, is it very hard to communicate with face mask people with the disability, open lip ribs, to compensate for their lack of hearing? Is there clear mask being distributed to the community groups or anyone on the health sector to help with this issue?
Not that I know of, but that's a really good question, and it's one that we can bring back because the same question is being asked for kids, actually, for daycares and schools, because for a slightly different reason, but the same basic idea is that being able to see a teacher or educator's mouth is part of kind of the interaction with kids. So it's something we can bring back. It's a very good question.
Thanks. There's a question about churches. Will there be guidelines for churches right now?
So I don't think that we are going to be doing anything specific in Montreal unless we see a really big gap in what is produced provincially, because there is interfaith committee that has been working with the ministry for a while now, so representing variety of Christian denominations, the Muslim communities, Jewish communities, and what they've been working on, entre autres, is some of the guidelines for their settings. So I expect, and what I've seen, I expect that that will cover, that it will be sufficient, and that we won't be putting out specific guidelines on our end. And in terms of timing, again, as far as I know, it should be very soon.
Okay, great, thank you. Back on water fountains, most of the water fountains are not operating right now. Do you know where's the directive for cities to follow?
What I had, so again, I said the map isn't public because it has some limit. It can't really be used in the same way as the map of pools and stuff, which is really, you can click on and say, okay, this pool is open, this pool is closed. The water fountain map doesn't work that way. But what I saw is that there's water fountains all across the board that should be open. I would say if there are water fountains in your neighborhood that aren't functioning, I would suggest calling 311, because I think it will be, specific to a borough, is like, why is that one not open, or why is that one not open? Because the information that I have, and I mean, it's high level, I have the information not from going to check the water fountain, but from what I have from the city in terms of map of the open ones. But to me, it looks like it covers the territory well. So I would suggest on a local level, if there are things that are not open, is to check with your borough or your city if you're in a demerged or with your city if you're in a demerged community.
Thanks. Another good question is about testing. So some homeless shelters want random testing as many people as possible, while it appears that Quebec is following contact tracking as opposed to random testing. Would there be a good reason for a shelter to require random widespread testing?
It comes back to what I said before. I think that there are pros and cons to, let's say, both. Sorry, this is an extended noise making session. There are pros and cons to both ends of that spectrum. And right now we're in a context where we have still some community transmission, but it's much lower than it was a few months ago. But we can expect that it may pick up again at some point. I mean, it's hard to predict. And so I think it depends also on that. The pertinence of regular systematic testing depends also on how much transmission there is in the community. So I don't think there's a wrong answer. I would come back to the most recent ministerial directives include homeless shelters and other, as I said before, other closed or semi-closed environments with at-risk clientele in the priorities. And so it's not, in fact, that orientation ministerially, it would go in the direction of being able to do systematic testing. After that, I think it's operationally doesn't make sense. Are the pros greater than the cons? And I think part of that depends on where we're at in terms of community transmission.
Thanks. Another question here is on specific situations or organizations' particular needs. Would we be able to contact one if you so specific need? If we'd be able to, oh my God, that one's hard to read, I don't know why. Would we be able to contact one if you directly to review our protocols, our way of organizing our care? About that, I'd just like to specify that was also asked in the French webinars, and we just don't have the capacity to review all the protocols and all the ways of organizing the resuming of activities. So, but we can be involved if ever there's an éclosion in your organization. So that would be the answer that was given in the French webinars. David, would you like to add something to that?
I was going to delegate Karine to review all of your protocols, but
yeah.
Oh well, she spoke first. No, yeah, it's absolutely right, and it's the same as for workplaces or all kinds of other settings. What I would say is that once we have gone through these webinars and the questions and responding to those questions, we'll see see if there are unanswered, with the tools that are available, if there are unanswered elements. And also, I think it's important to remember CLSCs, the community organizers that are already present in the community and who we are in touch with through their teams. And to the extent that you have more general questions, I think the first idea would be, like health related, would be to reach out to the community organizers, and then if there are technical elements or specific questions, then that may come back to us. But I think it's important here is that the basic principles are very, very simple. And so it's really the adaptation to your context that is, that maybe, may require a little thought. And because you are the experts of your specific context, of the physical environment, of the clientele, of the constraints and opportunities, I think that it really comes down to that. And nothing will be perfect, and nothing will be zero risk. And I think that's important too, is to always come back to the objectives. The objective is to control COVID risk, but also control negative impacts or side effects of the things that we're putting in place. And so in that sense, I think you're also the best judges of what works in order to deliver your services, bring your services to the community, while making sure that they're safe.
Thank you. Another question here is on, are there any special recommendations for seniors starting to use public transit again?
No, I would say again, the people who are more at risk, so whether it be seniors or whether it be people with chronic diseases, it's really just a matter of making sure that those individuals have maybe a little more individual burden for making sure they practice rigorous hand hygiene. Those people should be wearing face covering, if not a mask, when they're in settings like public transit or in malls or public settings where they're in interaction with people at close distances. But otherwise, there are no specific restrictions. And I think it's important, again, the risks. We have this many. What is this? Cases that we have linked to transmission in public transit in Montreal. So that doesn't mean that it can't happen, but I think it's really important to put that risk into perspective and say it's much more important for people to get out, access services, live their lives, and stay sane, than to avoid a very, very small potential risk if they do. If everybody does what we should be doing, but especially if they do what they should be doing, which is hand hygiene and respiratory etiquette and wearing a mask and physical distancing.
Thank you, David. So next question is from Rosemary. Will you be sending us these questions and answers sent us along with the PowerPoint? So the answer to that is not in a short time. Actually, we want to share the presentation right after this webinar, but for the frequently asked questions, we want to do a tool, but it will not imply all the questions we've asked. Plus, we want to put the audio or video version of webinars on the web, so that's going to be also a tool where you can hear the answers that were given to questions. So hopefully that answered your question. Would there be any more questions for David Kaiser?
Karine, I see many more questions after the one you just asked.
I have problem with okay. I have problem with my computer. I'm so sorry. I'm just going to turn off and go back to my phone. The moment.
Okay.
Yeah. I just saw them. I don't know why they were not on my laptop, but I see them on my phone, so I'll try to read them from there.
Do you see
our network? Yep. Thank you. Thank you for the clarification. Okay. Our network kept working during the confinement period. Concerns about burnout for staff How do we get support to maintain HR? Should teams still rotate between two waves or staff to prevent an outbreak?
So I don't have an answer for support for HR, unfortunately, sorry, but I think probably part of that is bringing it back up to the people who finance you and letting them know that that's a need, honestly. And otherwise, should teams, trying to find should teams rotate? Should teams still rotate between two waves of staff? Oh, okay. I think the idea here being what are some of the administrative measures that can be put into place in order to reduce risk. And for sure, the idea is you're always trying to limit mobility as much as possible. And so that starts at, say, you're always at the same seat at the table. You're always sitting across from the same person. You're always eating with the same group. And ainsi de suite. So for work groups, it's the same idea. As you're always, ideally, the individuals are, if you have 2-3 groups of employees that are using a shared workspace, for example, but the same person should always be using the same workspace day after day or each time they come in. That ideally you keep tandem, duos, or trios together. And keep them stable as much as possible. That effectively, so between shifts, there's as little movement as possible, and in that way, if there's an outbreak, also it makes it easier to contain your HR impact because the contacts amongst your staff will be less, and so it's for reducing maybe the likelihood of transmission, but it's also for reducing impacts if you have a case or when you have a case. These cases will happen. So obviously that's to the extent that it's possible. And there's organizations, if you have more employees and less specialization, it may be more possible than if you have less employees or more specialization between your employees or your staff. But that's always the principle, is thinking also about if one of my employees is sick, how many are going to be impacted by that, and what's going to be the impact on my ability to deliver services, and trying to put in place the administrative measures to reduce that impact. Does that answer that question?
Hopefully it did.
Like this.
Yeah. Maybe 1 or 2 last questions. Here we have, when surgical masks are recommended for employees at high-risk intervention, are cloth mask and face shield a good replacement? So
for high risk intervention, I guess depends what that means. Let's say a anesthesiologist intubating a COVID positive patient, we'd have to be really, really far along the spectrum of shortage of equipment to replace PPE with a face covering. If it's you're working with, say, adults with dementia or kids with autism, and you can't predict always that they'll maintain that distance, or there may be possibility of physical contact and all that kind of stuff. I think that it's a matter of to some extent, a matter of choice. Cloth masks are not a direct replacement for surgical masks with everything we know at the moment, but we know more and more about what they actually do, and we have more and more information about what is most effective. And so cloth masks, for example, with a filter, so with multiple layers and with a filter, can actually be quite effective as protection. But if we're talking about really interventions where you might be getting, spit on or bitten or I don't know what, depending on what kind of interventions you're doing, then I think that PPE that should be situations where you're prioritizing PPE.
All right, thanks. So I think that's all for questions. We could probably go to the conclusion of the session. We can display the PowerPoint for the last slide.
I will read this slide just so it's indelibly imprinted on your memories. So as you saw, it's really very straightforward. So the idea, and that may be more or less satisfactory, satisfactory, but choosing to resume your activities is really up to you, according to what's possible, according to what your context allows, and there's no one size fits all. I think that it's really important to limit the number of basic principles that are being used to orient your work, and those are really on that first little F-shet. It's distancing and respiratory etiquette and hand hygiene, and wearing face covering or PPE in situations where that's difficult. And then after that, it's really looking at if we want to mitigate or minimize COVID-related risk. There's probably some activities that should be maintained in an adapted way for months to come, but that if we want to mitigate or minimize overall health risks, including mental health and psychosocial health, then there are some activities that should probably be resumed in a way that will mean that you're interacting with your clientele, because that's what you do. So next steps, as Karine said, is sending the presentation out and then working on the frequently asked questions. And as Karine said, we don't want outbreaks in community organizations, but we know that cases will occur and that there's a potential for outbreaks at all times. And that's where we'll also be in support, making sure that we limit the impacts on your ability to deliver services. So thank you very much.